1 in 2 females over 50 and 1 in 4 males over 50 are likely to have an osteoporotic fracture. There are more hospitalizations every year for osteoporotic fractures than there are breast cancer, stroke, and heart disease. If they've had a fracture and they're on commercial insurance, we can get them approved for the bone builder, no problem. Insurance company or the pharmaceutical company has this copay card, so they get it for $0 to $4, but they have to be approved. So once they're approved, commercial, no problem. So any patient that's not on Medicare that's had a fracture, I want to get them on the anabolic while they are on commercial insurance, because the minute they go on Medicare, they won't be able to afford the anabolic that we want to put them on, because that goes under their Medicare Part D, and they can't afford it. So it would be, at that $600 to $1,000 a month for 18 to 24 months of treatment. And there's no pay. Well, the Medicare patients are the one that need the treatment. Their bones are older than the younger. It makes no sense.
There's no way to administer it in the clinic, so it's under Part B?
Nope, you can't do it because it's self-injection and it's daily. Now, the only other medication that's an anabolic is the Evenity. It's got anabolic properties, but it also slows bone loss. But it's $22,000 a year versus the 𝗫𝗟, which is not the same medicine. It also slows bone loss, but it doesn't rebuild. So what happens is the insurance company will come back and they'll go, we won't approve Evenity. We want the patient needs to try and fail an oral, an IV, or denosumab, which is Prolia. Or the oral medications are under the pharmacy benefits. The sub-Q daily injectable to rebuild teriparatide and abaloparatide, those are under pharmacy benefits. The IV once a year, the every 6-month injection, those are Medicare Part B. If they're on an Advantage plan, sometimes the Advantage plan may let us put it under their pharmacy benefits, but it's going to get them to the donut hole or catastrophic much faster, or non-coverage. But rarely does that happen. We usually have to go through Medicare Part B, and then Evenity is the bone builder and suppresses turnover. It's 2 injections monthly for 12 months. That's it. It's 12 months, $22,000 to reduce a $100,000 hip fracture or spine fracture, or put them in a nursing home because they had a broken bone. 22,000 versus, okay. So insurance is going to pay either way, but it's ridiculous, right? Well, if I have a spine fracture patient and they're Medicare and they're female, so Evenity, the monthly injection for 12 months, that is not covered. It's not indicated in males. It's only indicated in females. But this is what's interesting. It is the only medication that we have that provides 73% fracture risk reduction in the spine. Everything else is 50, 60, 65%. That's 73. So you have a patient that comes in and they've had a spine fracture. They just had a kyphoplasty done because of that spine fracture. 9 times as likely to have another spine fracture. If they've had one, 15 times as likely. So what I'm trying to do is I want to put them on a medicine that's going to provide maximum fracture protection, right? They have to go on something that won't rebuild their bone before. It's ridiculous. So I have to appeal it. I mean, it's nuts. But if we could treatment sequence like we're supposed to, put them on the anabolic, then put them on the anti-resorptive, monitor their bone densities. As long as they haven't had a fracture, their bone density doesn't decline, they're on the cheaper medicine throughout the course of their life. But if we start with the other and they actually have a fracture, we're right back to where we were, and it's costing them more. It's just, it's unheard of. It's crazy.
So if a person needs the more complicated, what'd you call it?
Bone builder, anabolic.
Yeah. And they're on original Medicare. So Part B is going to pay for that.
Yeah. So I think it's important so there's 3 medications that increase bone formation. 2 of them are considered pure anabolics. In other words, they build bone and they remodel bone.
Anabolic as in like anabolic steroid?
No, not like that, but anabolic as in naturally occurring that stimulates another process in the body, right? So there's 2 that are, one is a parathyroid, it's the first 1 through 34 amino acid of the parathyroid hormone. That's teriparatide. The second one is a related protein to that parathyroid. So when you when you get pulsatile doses of the bone builder, the parathyroid treatment, when you get pulsatile doses, which are daily injections, you build bone and you remodel bone. So you're actually removing old bone and you're putting new bone down. So it makes sense that if you're younger and you're going into menopause, or you're older and you've been on medications, steroids, or whatever that can affect, you want to get rid of some of the old bone and lay new bone down. What it does is it takes the person back to their premenopausal phase of bone remodeling. So it basically, they're building bone faster than they're losing. Okay, and that's what happens. The other medication is an anabolic-like drug, but it does build bone and it increases bone formation, but in a completely different pathway. That medication is called romosozumab. The two that I was just talking about, those are daily injectables that are self-administered, so they always fall under Medicare Part D or a pharmacy drug plan, whether they're commercial or not. For the commercial pay patient, they get a copay card because they have these incentives and these rebates and all that, and they pay $0 to $4 for their treatment. Medicare patients, however, because they're already so deeply discounted and they have these, these formularies and whatnot, that, restrictions and all, their cost, they have to pay 1/3 of whatever that drug cost is. So I blame the pharmaceutical company also because their price is too high. It's way too high, like insulin. But if the patient does get approved for that treatment, they have to pay $600 to $1,000 a month because they have to pay 1/3 of whatever that drug cost is. Unless they qualify for patient assistance, or unless they have some other kind of like TRICARE for life, no problem. They get it. So why is it that those people get it covered, but other people can't? Access to care is crappy. The anabolic, that is the monthly injection, the anabolic-like medication, that's the monthly injection, it's always covered under, for Medicare patients, it's always covered under Medicare Part B. If they have traditional Medicare and a supplement, no cost. Doesn't require a PA, and they get the treatment. If they have a Medicare Advantage plan, depending on what their Advantage plan is, they have to pay 20% of whatever the drug cost is. 20%.
Right.
Of whatever the drug cost is until they reach their out of pocket, which could be $3,600, $4,000, $6,000. So say you have a really healthy Medicare patient. Healthy. They're really not on any medications or anything like that, and they come in and they have osteoporosis, and now they have to face the fact that they have a chronic disease, that they haven't had any problems, and now they have this chronic disease. Well, they took out the plan that they would have a $6,000 deductible because they never go to the doctor. They've been healthy their whole lives. And now we're telling them, oh my gosh. So they have to meet that out-of-pocket deductible before it's going to be covered 100%. Whereas if they were a healthy Medicare recipient on traditional Medicare and a supplement, no problem. No out-of-pocket, nothing. Right?
What is the typical age that this is a problem, or the typical first treatment age that you're seeing for people with that?
You mean for coverage, or
like when they're seeking treatment and you're like, this is what you need?
Okay. Well, so first of all, any patient with osteoporosis should consider a treatment to treat the osteoporosis to reduce the risk of the complication, which is broken bones, fragile bones. So we can diagnose osteoporosis in several different ways. We can diagnose osteoporosis if they truly have osteoporosis on a bone mineral density test. We can diagnose it that way. We can diagnose osteoporosis if someone actually has low bone mass, or what people, patients often say osteopenia. That's considered low bone mass. If they have low bone mass, but they have a high risk of a fracture in the future. The way I tell my patients this is, I say to them, when you go to your doctor and your doctor says, you haven't had a heart attack or a stroke, but you have high blood pressure and high cholesterol and you have family history, so your risk of a heart attack or stroke is higher, but you haven't had one yet, but your risk is higher, so we would recommend treatment to reduce your risk. That's what we say in osteopenia. If they have high risk of a fracture, and there's certain risk factors that we would, clearly vet out. But if they have those risk factors, then that's considered osteoporosis by definition. Even though they don't have osteoporosis on their bone density, it's considered osteoporosis by the fact that they have low bone mass and they're high risk for a fracture. The third way that we can diagnose osteoporosis is if someone has had a fragility fracture, and doesn't matter what their bone density is, because if they had a fragility fracture, by definition, that's considered osteoporosis. That is age dependent. So if they're greater than 49 and they've had a fracture that occurred that would have not, it may have been a traumatic fracture, but that traumatic fracture would have not have otherwise occurred in a healthy adult or a patient with healthy bones. So for instance, a good example would be if someone is wearing their seatbelt and they get in a fender bender and they have a compression fracture in their spine. That doesn't make any sense. Why did they fracture in their spine? That if they had really good strong bones, that type of an injury should not have created a thoracic or a lumbar fracture. So there's something going on in the quality of the bone, right? So I think the other way that when you think about treatment, we're not just interested in the bone density. We're interested in the total bone strength of that patient. We want their bone strength to be optimized and maximized, because every time they age, every time they have a birthday, their bones are going to have a birthday and age with them. They can't feel it, but that's happening. So at any point in time that they see me, that's the first thing I talk about is I say, it's not so much about your bone density. It's about your bone strength. And your bone strength is made up of the quality of your bone and the density, which is the thickness. So if I have a diabetic, the research shows that a lot of diabetics, many diabetics, they're going to end up having normal bone densities, but they have fractures. Why? Because we know that that disease affects the quality of the bone regeneration. So they're still building bone, but that quality of that bone is not as good because of the diabetes and what sugar does on the cells that, that have to do with bone modeling. So quality is a big issue, right? So if we want to improve the quality and the density, we would like to put them on an anabolic agent, and especially if they're high risk and they've had a fracture. The challenge that we have is that many of the people that sit on insurance boards for these tiers, many of them are other types of specialists. So you may have an endocrinologist, you may have a rheumatologist, you may have, I don't know, usually not integrative medicine, but I would say the other specialists that deal with bone health. So the problem in osteoporosis is that we don't have consistent standards of care for every specialty that treats osteoporosis. If you look at the American College of Clinical Endocrinology guidelines or the American Academy of Clinical Endocrinology, and you look at the American College of Rheumatology guidelines, there's a little bit of a divide in what they would recommend for bone density testing, treatment, sequencing, etc. But if you talk to an orthopedic provider who specializes in bone health, who has seen the fractures, who understands, that process, well, those protocols are a little bit different. So the science is now evolving to sort of merge any of the discrepancies or inequities within those, protocols. We're trying to merge those with the data, and the new data that is coming out indicates that the postmenopausal woman who's at high risk for a fracture should go on an anabolic treatment first. Okay. And so that's what we're trying to practice on. Now, in the real world, we would love to put every patient that has osteoporosis on an anabolic first. They already have significant bone loss. They're already osteoporotic. Even if they haven't had a fracture, why wouldn't you want to put bone in their bank account?
That's preventative, right?
Yes. Why wouldn't you
just say it's insurance in the end?
Why wouldn't you want to build bone? Well, that's because the protocols that we have are all over the place. And so when the older protocols came out, they only focused on just treating osteoporosis. Just treat it. Treat it with a medicine to slow the bone loss down, because they're all going to reduce the risk of fractures. Every one of them. But some are better than others. Some are 50% fracture risk reduction. Some are 40% fracture risk reduction. Some are 60, 65. One provides 73% fracture risk reduction in the spine. So why wouldn't I choose the one that gives me the most? I'm the consumer paying for my insurance. Why shouldn't I get the choice of what I want to do for my bone strength? Because I can tell you, my insurance company doesn't want to pay for me to go to a nursing home. They don't want to pay for my hip fracture. They don't want to pay for my spinal surgery that won't take. They don't want to pay for my total joint that my hardware's backing out. They don't want to pay for any of that. Why shouldn't I be able to choose the best treatment for my bones? Right? So
what's the process like with a Medicare Advantage company when they say, no, we're not going to pay for the most expensive thing that they need right now?
There's several levels of appeal that you can do. It's very difficult to get them to start the process of appeal, but I'll tell you how it works. So we get the first denial, and then we try to send more information in, and we ask them to look at this again, and then we ask for an appeal, and somebody will look at it again, and they'll just come back and they'll say no. And then I'll say, I want to do a peer-to-peer evaluation. I want to do a peer-to-peer consultation. So I have to take my time away from other patients that I should be treating, just to wait, schedule an appointment that's convenient for them when they have their paid specialist that works for that insurance company to make the decision again for my patient. I literally have been on the phone, like you would not believe, with a number of people. Insurance companies used to have any kind of specialist do the call. So I would get on the phone, as I'm the bone health specialist, and I would get on the phone and I would be talking to a peer-to-peer. So it would be a provider that was supposedly like an MD or whatever that was equivalent to my knowledge base. And they would say, no, the insurance, the patient doesn't meet the criteria. And I was like, yeah, the criteria on your plan. What is your specialty? Oh, I'm a GI specialist. What do you know about bones? They don't. Now the insurance companies have gotten wiser. Now they're hiring orthopedic providers and endocrinologists. They're having pharmacists be peer-to-peer. So pharmacists are getting on. Now, here's what happens at the peer-to-peer level. If I show that I have more knowledge around this patient's disease state, and the patient is literally in front of me, I have evaluated them, I've seen them, I've examined them, I know what their risk factors are, I've got all this documentation, and I'm telling you, this is the treatment that this patient needs for their best outcomes, for optimized bone health, bone strength. They'll still say they don't meet the criteria. I don't understand that mentality, but many of them will end up saying, oh, I get it. Well, that could make a difference. I'll check through it again and see. So then another delay. And I'm like, oh, this sounds positive. They come back and it's still denied. So they just basically told me that they would be an advocate for the patient, but they're not, because they're going to be an advocate for the insurance company, because as long as they can keep their insurance costs down, they're going to be a paid consultant to be able to do that. It's absolutely ludicrous. It's political. And so
you're saying you don't have those troubles with original Medicare people with a Medicare supplement on Part B administered drug?
We don't know, because it doesn't require a prior authorization.
Right.
And there's no tiering. There's no criteria there, because it's basically a pure 80-20, because it's a medical benefit. Now, we struggle when it comes to those other two anabolics that are self-administered, because those are under Medicare Part D,
which is the same house as an Advantage plan.
Yeah, exactly. So they're under Medicare Part D. The patient has to pay a third of whatever the drug cost is, because it's self-administered. It falls under the pharmacy benefit. Well, whereas this other one, the monthly injection that provides building and slows bone loss, we get 100% covered when it's a patient that's on traditional Medicare and a supplement, because it's 80-20 pure. 80% is paid by the medical, 20% is paid by the supplement of the medical. So therefore 80-20, the last I counted, is 100%. No cost. Okay.
If you had your choice, let's say you're 65.
Traditional Medicare with the supplement.
Why do you say that?
I would rather pay monthly for a supplement and a drug plan to have control over my life, to be able to make my own decisions, to be able to choose that I want the best quality outcomes in my life. Don't take control from me. I've earned the right to age well. And I've earned the right to make the decision on how I want to age well. I don't want somebody dictating to me who's sitting there, who is, 40 years old, who hasn't experienced the diseases the challenges of life that I've had. They don't know my circumstances. I want to be able to sit down with a provider that knows me, that knows what my goals for quality of life are. I want to be able to sit down and I want to be able to make a decision based on that. Not somebody who hasn't ever laid eyes on me and doesn't know anything about me. I'm simply a number. If you want to break a bone in the future and you have osteoporosis, but you don't want to take medication, then ask yourself the question, if I make this choice, am I going to meet the goals that I really have? Otherwise, I'm going against everything that I really want to do. And then they're like, okay, well, what are the meds again? I'm like, okay, great. Let's talk about them. Let me empower you with the knowledge you need to make the best decision for yourself before you make a decision. Then you'll have all the knowledge. Don't do Dr. Google. Don't, let me talk to you. This is what I do. This is my specialty.